All right, and I'll throw these up again at the end in case anyone misses them right now. At this point, I'm not going to spend a lot of time here. Main thing is like, just know that you guys are so close. You're doing so well. This is, believe it or not, your last unit exam before the final, which means, again, you are so close to being done. Um, Again, talking out loud when you're studying, pretend you're teaching to your patients or your stuffed animal or whoever it needs to be. Breaking your studying into chunks. Sometimes it's really hard to sit down and study for 8 lectures worth of material in one go, but if you can pick one or two and, really get that down before you move on, um, that's a great way to kind of build up your studying without it being super overwhelming. And then for the final exam, again, I'm going to look at that tutor review session and see about maybe doing that in person if it would help you guys. But in general, as you start preparing for the final, use all the materials that I sent you previously, use the YouTube videos, because those will, again, just kind of highlight those really important things that might pop up on your final exam. So the exam breakdown for this week's exam, you're looking at 23 questions on endocrine, about 50-50 split between pathophys and medications, and then about 26 questions on hemostasis and anemia, with 17 on pathophys and 9 on your meds. There are 49 questions. You guys are super, super lucky. There are no select all that apply, and there is one next generation NCLEX question that's going to be worth 4 points. I didn't hear it from the professors, but I did have one of your classmates tell me that it was a prioritization question. So just when you're looking through content, or an ordering question maybe, when you're looking through your content, see where maybe that next gen question could come up to help you prepare for that. So to get started, we'll start with the pituitary gland of the endocrine system. The pituitary gland is your master gland. It is primarily responsible for hormone regulation. It is primarily controlled by the hypothalamus, and it's broken into your posterior and anterior pituitary. The hypothalamus is your little relay center. It takes the signals that the body's giving it, delivers those signals to your pituitary, and tells it what to do. So TSH, for one, your thyroid stimulating hormone, if that's low, if your thyroid is low in your body, your hypothalamus will take that signal and go tell your pituitary what to do with that and say, hey, release more TSH. So your hypothalamus is that they in the slide it says like key for interrelatedness. That's just saying it's interrelated between your body and your pituitary. It's that middle part for communication. The three main anterior pituitary hormones are your adrenocorticotropic hormone, your thyroid stimulating hormone, and your growth hormone. And from the posterior pituitary, you have your vasopressin, which is also ADH. So with your pituitary, you can have hypopituitarism, which is just the undersecretion, either from disease of the pituitary or again, disease of the hypothalamus, since the hypothalamus regulates the pituitary. And then you can also have the opposite, hyperpituitarism, pretty straightforward, it's just the oversecretion of hormones from the pituitary. You can also have various tumors of the pituitary. Some examples are listed there. Some important things to remember though, functional tumors secrete hormones. So those can almost mimic your natural pituitary and still secrete hormones. Maybe not in the right amount, maybe you'll see more or less of a certain hormone, but they are capable of secreting them. Whereas your non-functional tumors do not secrete hormones. Those are just tissue and cells that kind of build up in there. A basophilic tumor often is linked with Cushing syndrome, which we'll talk about more in a bit. A chromophobic tumor is a type of pituitary tumor that doesn't specifically secrete hormones, but as it grows and develops, it destroys your pituitary gland. That can be pretty serious. And an eosinophilic tumor can cause gigantism and acromegaly, which are some of these endocrine growth imbalances that we're about to talk about. Gigantism is the excess of your growth hormone, it's shortened to GH, early in life, so childhood primarily. With gigantism, your patient will grow very tall and very large in proportion across the body. That's a key differentiator between gigantism and acromegaly. So in addition with that proportional excess growth, you're going to see weakness and lethargy because your body is just not meant to be of that size. So when you have this excess metabolism required to complete all of these, growth processes or just simply keep that big of a body alive, you're going to have some weakness and exhaustion. In comparison to gigantism, acromegaly is excess growth hormone in adulthood, and growth is not proportional. Growth is going to be limited to your feet, hands, molar eminences, nose, and chin. So I'm sure you've seen some pictures. These people have very specific parts of their body that are larger than others. This one can cause bone weakness, impaired glucose tolerance, hyperinsulinism, and insulin resistance. So there's a pattern there with glucose and insulin and how those can coincide with a diagnosis of acromegaly. Octreotide acetate is the prototype drug for acromegaly. This works by decreasing your growth hormone. Um, some adverse effects there, you can have CNS effects, cardiovascular like bradycardia, increased blood glucose, nausea, diarrhea, and cholelithiasis or those gallstones. For octreotide acetate, it's administered IV, IM, or sub-Q. As always, if it's sub-Q, you want to teach your patient to rotate those injection sites so they're not always going in that lower right quadrant or whatever it might be. Something important with octreotide acetate is that you will help your patient and teach your patient to withdraw the medication for 4 weeks once per year. That's like a very unique thing. You don't see that often. Um, just know that kind of education piece, that guideline for sure. Dwarfism here is kind of the opposite of gigantism. It's caused by insufficient growth hormone production from that anterior pituitary. The main treatment here is somatotropin. It's a medication that's basically a synthetic hormone. So it'll stimulate your skeletal, linear muscle, and organ growth. The most important thing here is that the drug is no longer effective once long bones have closed. That is a key piece of information. Um, the drug as a whole is evaluated by monitoring your growth. So if a person reaches a satisfactory height, satisfactory growth, we can stop that medication even if their long bones haven't closed yet, for example. Diabetes insipidus. This one I remember tripping me up just because I think diabetes, I think insulin, I think, the pancreas. This is just a different mechanism. This is not your typical type 2, type 1 diabetes. Diabetes insipidus, or DI, is the deficiency of ADH, that hormone from your pituitary, and it causes extremely large volumes of dilute urine and extreme thirst. The most common cause here is head trauma. I would know that for sure. And your clinical manifestations are going to be those large amounts of dilute urine, extreme thirst, and symptoms of dehydration. Desmopressin is a drug for DI that works by replacing your ADH. It works to increase that reabsorption of water in the kidneys, but there is a black box warning for severe hyponatremia. And if you remember from last unit, that puts the patient at a very high risk for seizures. So on the exam, you know, it might not say, oh, there's a black box warning for hyponatremia, but maybe there's a black box warning for seizures, and you should be able to put those together, or knowing that the patient on desmopressin is at a higher risk for seizures because of this risk for hyponatremia. Desmopressin then is evaluated by a decrease in urine output with decreased thirst and signs of dehydration. So just looking at those symptoms and looking for improvement. With SIADH, that's syndrome of inappropriate ADH, the body fails to regulate that ADH, causing an excess of ADH in the body. This ultimately just causes increased fluid volume and water toxicity, water intoxication. Manifestations here, we have low urine output, high ADH, hyponatremia, so low sodium, overhydration, and excessive thirst. And I think on my next slide, it must not be here. It's somewhere in here. I put, if it's not in my PowerPoint, which I think it is, there's a slide on your professor's PowerPoint that has a list of symptoms of DI and SIADH, and it like says at the bottom both have excessive thirst. That is a great, great slide to use to compare the two. And I think it's in here, so we'll see if we get to it. But if not, definitely look at that slide to compare the signs and symptoms of the two. Which of the following hormones is secreted by the posterior pituitary? Awesome. Yep. That is C. The other three are all going to be your anterior. Your pediatric patient was diagnosed with dwarfism. The patient has taken somatotropin for years. The doctor has discontinued the medication, and the patient's mother is expressing anger, repeating that the medication helped her child so much. What education do you need to provide as the nurse? Awesome, guys. Yep, that is D. Just doing that bit of education of, you know, we looked at x-rays, we did whatever, which the provider will have done. And once it's determined that long bones have closed, somatotropin is not going to be effective for growth purposes anymore. Which of the following clinical manifestations is not a characteristic of diabetes insipidus? Diabetes. I never call it that. That's what Sandy calls it. Diabetes insipidus. Great. Yep, that is B. That would be a characteristic of SIADH. So everyone got that one as well. Oh, here it is. I knew it was in here. I thought I was going crazy. This is a really great chart to use, just because it summarizes those key signs and symptoms, for you to do a quick compare and contrast. Moving on to the thyroid. Your thyroid is a gland, sits right about here. It is responsible for the secretion of three hormones. You have T4, T3, and calcitonin. Calcitonin is just kind of a unique one, just as a function explanation. Calcitonin is secreted when your body has high levels of calcium. So calcitonin, even though it kind of sounds like calcium, it's going to do the opposite and bring your calcium level down in your blood. For these hormones in the thyroid, your body requires some level of iodine to make these. Let's see, T3 and T4 are hormones that are involved in metabolic activity and cellular replication, which is why, as we'll see when we talk about it, the thyroid hormones have such a big role in your entire body health because they're responsible for the cells that make up your entire body, which is why thyroid issues can be pretty serious. And then your TSH is the thyroid stimulating hormone that's released by the anterior pituitary, and that just controls your secretion of T3 and T4. Your primary tool for screening thyroid health is going to be that serum TSH. And then you can also do labs for free T4 and then your free and bound T3 and T4 as well. But definitely know the serum TSH being that primary tool. So hypothyroidism is exactly what it sounds like. It's going to be low performance of the thyroid, low circulating TSH. It's most commonly caused by Hashimoto's disease, which is an autoimmune condition that impairs the thyroidal function. So with low thyroid hormones, you're going to see low metabolism. So your entire body is going to slow way down. So you're going to see fatigue, lethargy, weight gain. You can't metabolize what you put into your body. Dry skin, hair loss. You can have brain fog, bradycardia, so slow heart rate. And then we're going to talk more about myxedema coma here. But when you think of hypothyroidism, I want you to think low metabolism, slow everything, low and slow. Everything in your body is going to slow down with that. For treatment, the drug of choice here is levothyroxine. This is just synthetic thyroid hormone. Wow. It's often called Synthroid. Maybe you've heard that in the clinical setting. The dose is titrated because the amount obviously varies with each person. And it can reach toxic levels, which is why we just monitor TSH pretty closely while we administer it. Education there is to take it in the morning on an empty stomach and typically with a full glass of water. The main adverse effect here is that by taking too much synthetic hormone, you can produce the signs and symptoms of hyperthyroidism, which makes sense. You're taking too much thyroid hormone, now you're overdoing it, and you're going to create those opposite signs and symptoms. Myxedema coma is a life-threatening condition from severe hypothyroidism that can be fatal because it can cause cardiovascular failure and shock. Some main symptoms here are going to be severe and profound hypothermia, being unconscious, and super low respiratory rate. So think all the things that were already going slow, they got really, really, really slow and low. Treatment here is close monitoring of your respiratory status and preparing the patient for potential ventilation, passive rewarming to work on that hypothermia, and cautious use of fluids. So the opposite of all of that hypo talk is going to be hyperthyroidism, most commonly caused by Graves' disease. And these are things I would know. Knowing hypothyroidism is Hashimoto's and hyper is Graves'. That's definitely something to know. So this is the excess output of thyroid hormone. So it's going to cause increased body metabolism and fast and high symptoms. So where hypo is low and slow, hyper is fast and high. You're going to see anxiety and restlessness, tremors, tachycardia. You can see bulging eyes, increased drug metabolism, and weight loss. So pretty polar opposite to hypothyroidism. Where myxedema coma is the major concern with hypothyroidism, a thyroid storm is your concern for hyperthyroidism. It is the acute release of excess thyroid hormone, and it is, again, life-threatening. It is often caused by an ablative dose of iodine or undertreatment of hyperthyroidism. Clinical manifestations here would be excessive tachycardia, fever. You can have circulatory collapse and arrhythmias. So again, everything is going too much, too fast, too out of control with a thyroid storm. For treatment here, you have a couple more options compared to levothyroxine for, low thyroid. You have radioactive iodine, which is actually the treatment of choice because one dose is effective. The con here is that it produces lifelong hypothyroidism. So it causes the need for lifelong hormone replacement therapy of levothyroxine or Synthroid. Just because that radioactive iodine essentially is going to just destroy the capability of the thyroid to produce TSH. But consensus across the board is that hypothyroidism is safer long-term than hyper. So it's better to induce that versus live with hyperthyroidism, if that makes sense. Another medication here is propylthiouracil. This will work by inhibiting your hormone release. One of the downsides is that it does take days to weeks for effect. You can have symptoms of hypothyroidism, leukopenia, and acute liver failure. So you have to monitor your CBC, your white blood cell count, and your liver enzymes. So you can see just even between these two, why maybe the radioactive iodine is the first-line treatment compared to propylthiouracil. For some adjunctive treatment, so these can be in addition to those, you can have various iodine preparations. There's also a saturated solution of potassium iodide. These are used very short term, and they're going to be, again, used in line with those other drugs we talked about. Propanolol can be used as well. It's a beta blocker. You can tell that with that OLOL ending. And it controls the cardiovascular signs and symptoms of hyperthyroidism. So it's not going to fix the tachycardia and the hypertension that maybe the condition creates, but it'll at least kind of hide those signs and symptoms, even if your thyroid is still producing TSH like crazy, or T3 and T4 like crazy. And then also there is a surgical removal option if it is bad enough. Your parathyroid has the hormone, parathyroid hormone. It regulates your calcium and phosphorus metabolism, and it consists of 4 glands that are embedded in the backside of your thyroid. So they also sit with your thyroid. Hypoparathyroidism is exactly what it sounds like. You have low parathyroid hormone secretion. Most oftentimes, it's actually just going to be caused by removal of the thyroid gland. It's pretty straightforward. And hypoparathyroidism in general is going to cause low calcium. So all of your signs and symptoms are really going to look like hypocalcemia. You're going to see tetany, cardiac arrhythmias, those types of things that we learned about last unit. Treatment, you're going to increase your calcium, and then if you can, you're going to work on treating that underlying cause, which if you're like me, I don't like when we're taught that because I feel like all the time it just says treat underlying cause, and that's not super helpful. But just remember you're trying to increase that calcium to prevent signs and symptoms of the hypocalcemia. Hyperparathyroidism, again, is just the opposite, overproduction of parathormone, which is just another way to say the parathyroid hormone. Clinical manifestations here, you can have bone decalcification, kidney stones, and increased calcium levels, again, commonly seen with heart arrhythmias. So, treatment here, you're going to see, honestly, just removal of your parathyroid glands. Parathyroidectomy is what that is. When a patient is post-op for parathyroidectomy, you're essentially inducing that hypoparathyroidism. So now you're seeing signs of hypocalcemia. So when you're in that post-op status, it's going to be super important to monitor for signs and symptoms of tetany to try to identify critically imbalanced calcium levels. Perfect. Okay. What is the drug of choice for hypothyroidism? Great. Yep, that's levothyroxine. Which of the following statements is not true regarding Graves' disease? Awesome. Yep. Getting a lot of C's. Perfect. Um, that's just false. That would be Hashimoto's. After a parathyroidectomy, what findings should you report to the provider first? Awesome. Yep. D. So that sign, I don't want to butcher it, but that is indicative of tetany. That's a positive test for tetany. So again, that's the number one thing you're monitoring for post parathyroidectomy. You can tell your provider that they have 7 out of 10 pain and we need pain medication. You can tell them that they're super lethargic coming out of anesthesia, which is a relatively normal finding, but your priority there is going to be D. Match the medication with its use. So, not saying it's the right answer, but you can say 1A, 2B, 3C, etc., and just match those up. So, I'll give you guys a minute. I don't want to rush people through this one, so I'll give you guys another minute. But I'm seeing a lot of good answers coming through. I'm like double checking to make sure everyone's right. Yeah. Awesome. Yep. You guys are right. We got 1C, 2B, 3D, and 4A. So I tried to switch it up and bring in a matching question for us today. Good job, though. You guys all got that right. So that brings us to the adrenal gland. Switched up a little bit. Your adrenal gland is made up of your medulla and your cortex. The adrenal medulla is the part of the gland that is responsible for norepi and epi, which is adrenaline. As we know from Unit 1, epinephrine is released in fight or flight and regulates metabolic pathways. We want to remember epinephrine that's going to stimulate your CNS. So we're going to look at things like increased heart rate, increased blood pressure. Maybe we're going to shunt blood away from digestion and your bladder. So those things might kind of slow down. Your adrenal cortex then is responsible for glucocorticoids, as in cortisol, mineral corticoids like aldosterone, and sex hormones being your androgens. A pheochromocytoma is a big fancy word. It just means the tumor of the adrenal medulla. So if you recall, if we go back a slide, the adrenal medulla is responsible for norepinephrine and epi. So if you have a tumor on that, you're going to see impaired function of those specific hormones. So you can have hypertension, which, as we know, with hypertension, you can see headache, sweating, palpitations, hyperglycemia, headache, hyperhidrosis, and hypermetabolism. Those are 5 H's, if that helps you remember those clinical manifestations as well. Treatment here is just going to be surgical removal. You got to take out that tumor, maybe take out that gland to protect it. Um, Typically, these patients have very uncontrolled hypertension just as a symptom. So we are going to try to control their blood pressure with medications prior to surgery. And then I have this bolded because it's important to know. During the actual surgical removal, the patient is at risk for a hypertensive crisis. So you're going to be closely monitoring that blood pressure, making sure it doesn't go too high. But immediately afterwards, that risk shifts to a risk for hypotension. So just knowing that, during the procedure, this is what you're looking for, but during post-op, you're looking for hypotension and being prepared for that potential hypotensive crisis then. So I talked to a handful of people this week, just kind of getting people's opinions, and Addison's and Cushing's disease seem to trip a lot of people up. Um, So I have some good information in here, and I pulled the same comparison chart from your professor's slides that I think helps differentiate the two of them pretty well. Um, so yeah, definitely don't let these scare you too much. Because again, like everything in this unit, it's a lot of opposites. If you can understand one, you can almost like process of eliminate your way into understanding the other one. So Addison's disease first is a primary adrenal cortex insufficiency. So again, we're going to think back, what does the adrenal cortex produce? Okay, that's those glucocorticoids, the mineral corticoids, your androgens, etc. So that will result in insufficient production of those steroids. Because of that, you can see increased loss of sodium, chloride, and water while retaining potassium. You can see decreased cardiac output, and you can see low blood sugar. Again, so labs, you're going to expect to see low sodium, low sugar, high potassium, high white blood cells. An Addisonian crisis, this is your life-threatening exacerbation of Addison's disease, and it typically is in response to stress or illness. So in your patients who have Addison's disease as an underlying condition, say they're hospitalized for a heart attack, or something completely different, you need to know that they are at a much higher risk for Addisonian crisis. And you need to know then that as the nurse, you should be looking out for severe hypotension, cyanosis, fever, nausea and vomiting, shock, and a salt craving. So just kind of thinking through that with, I'm trying to go back to the slide. Yeah, so with insufficient steroids, if those almost bottom out, essentially, you can start to see these clinical manifestations that I have listed here. For treatment, if you look at the two medications that I have listed, they both end with that ONE, meaning that they are also steroids, which makes sense. In Addison's disease, you have low steroids, which are those three by your adrenal cortex. So hydrocortisone is a steroid that's a combination of basically synthetic mineral corticoid and adrenocorticoid. And it works by decreasing inflammation and improving that sodium retention. So it's trying to offset what the Addison's disease is doing. Fludrocortisone then is is synthetic mineral corticoid that works to promote that sodium retention and potassium excretion. Again, which makes sense because when I talked about Addison's, we were talking about a loss of sodium and a retention of potassium. So this drug is going to try to balance that out a little bit more. It does have some adverse effects to look out for, like high blood sugar, low potassium if you lose too much, heart failure, hypertension, and also gastric ulcers. So Cushing's disease is the exact opposite. You're going to have excessive secretion of those glucomineral corticoids and androgens from that cortex. Oftenly, it's caused by prolonged use of corticosteroids, prednisone, methylprednisolone, all those types of ones that we talk about. So the clinical manifestations here, think about steroids in general. Those produce, poor immune systems, moon face, thin skin, poor healing, sometimes hypertension and hyperglycemia. All of those adverse effects from steroids that we give patients as medication are the same signs and symptoms of Cushing's disease as a whole. So you can have obesity, your fragile and thin skin, weak bones, moon face, which is just like a really swollen round face, increased infection, hypertension, and then in your diabetic patients, you're going to really watch their blood sugar for hyperglycemia. Ketoconazole is the medication for Cushing syndrome that works by inhibiting enzymes for cortisol synthesis. So it's going to way slow down that steroid production, cortisol. The main adverse effect here is liver toxicity. So if you see that there's an adverse effect of liver toxicity, you need to know that you need to be looking at their liver enzymes because those will be some quick key indicators of liver issues occurring. This is that chart that I was referring to early at the beginning. This is great for memorizing the signs and symptoms. This is awesome. It breaks it down super easy and it gives you those mnemonics. You know, Addison's is ads and Cushing's is Cush. This is a great slide. I would highlight this, whatever you got to do. Um, I also think in general too, Cushing's disease, it says it on there, but like the body has a cushion. You have a lot of excess fat. That's something that would help me remember that. But yes, money slide right here for sure to understand those signs and symptoms. Primary aldosteronism then is the condition of excessive aldosterone production. Clinical manifestations here are hypertension, polyuria, so excess urination, concentrated blood with excessive thirst, increased blood volume, and hypokalemia. So here, really the only treatment is going to be removal of an adrenal tumor because that is often the cause of primary aldosteronism. In that post-op status, you're going to be monitoring for fluctuations of those adrenocortical hormones. And, you know, if they kind of bottom out on those, we don't want to produce symptoms of Addison's disease, so we can administer corticosteroids, which again are primarily used for adrenal insufficiency. They are great at controlling inflammation um, and minimizing immune responses, and they can reduce transplant rejection in turn. All those adverse effects, guys, are the exact same essentially as those of Cushing's disease. So that's a really good, you know, if you know one, you know the other, and you don't need to spend time grueling on both. Um, so yeah, super similar symptoms there. Major ones, your poor healing, your risk for infection, hyperglycemia and diabetics is a big one. And then that moon face and weight gain you'll see pretty often. Which of the following are symptoms of an Addisonian crisis? Select all that apply. A and B for sure. I like that. Nobody's wrong so far. No one's also fully right, but nobody's wrong. Hey, no one's wrong. It's actually all of them. So again, just making sure you're studying those signs and symptoms. All of those will present with an Addisonian crisis. Which of the following is released by the adrenal medulla? I guess I feel like half these questions are just super like, oh, you know it or you don't. And then half of them are like actually somewhat challenging. I like to think. But yeah, you guys are right. That one's epinephrine. All the other ones are going to be your adrenal cortex. Which of the following medications are used to treat Addison's disease? Select all that apply. I'm meaner than your professors. I do select all that apply, even though they're not on your exam. They're just easier for me to come up with in my head, to be fully honest. Let me take a look. Okay, so I got a few different ones between private chats and the group chat. It's just going to be A and D. Those are your cortisol, steroid, mineral corticoid, glucocorticoid replacements. Ketoconazole is that one for Cushing's disease. It'll actually inhibit cortisol release, and somatostatins going way back to the beginning for dwarfism treatment. Ooh, this one might be kind of tricky. Which of the following manifestations are expected with Cushing's disease? Select all that apply. This really just comes down to how much have you studied these symptoms yet. I have to look too to make sure I know them. I'm reading everyone's trying to make sure that they're right. ACT. Yeah, a lot of you guys either have it or you're super, super close. It is going to be A, C, D, E, and H. B, F, and G are all going to be symptoms of Addison's. Um, but most of you guys got that right, or at least close to right. Good job. That one's kind of tricky. Some of those select all that apply. But again, that's just really testing your knowledge to see if you can just pick out those symptoms from one another. And I've said it already, but if you're struggling with that, those charts from those pictures that compare the two, super, super great for that. So that brings us to hemostasis and anemias. And I know this is new-ish content to you guys. I'm pretty sure you finished it today. So no biggie if this is, still a little bit intimidating. You have tonight, you have tomorrow, and a bit on Thursday as well to work through these things. Luckily, though, I think a lot of us have a base understanding of anemia, especially from A and P, so hopefully it's not too bad. As far as clotting pathways go, you have your extrinsic and intrinsic. Your extrinsic clotting pathway is faster. It's going to be activated first, and it's activated in response to injury. So typically, when injury occurs, your body's going to release thromboplastin, and that'll immediately send this cascade occurring. The intrinsic clotting pathway is a little bit different. It's a slower process that occurs when vessels are exposed to lipoproteins or bacteria. So these are more your infections. So this is when you can have a clot start to form without specific bleeding or injury. So really just different causative agents here between the different pathways. When you have a clot then that your body needs to destroy, you have a cascade for clot destruction. And I've heard again that maybe there's an ordering question on this exam. Here's a series of events. This is maybe potentially something that could come up in a next gen type of question. Your body, again, just a series, takes plasminogen and turns it into plasmin. Plasmin then is able to digest the fibrin and fibrinogen, which are key structural components of a clot. And once that digestion is done, that clot can dissolve. So that's kind of that clot destruction cascade. Anemia. I would put money on it that a lot of us have heard of anemia before. It is the most common hematological disorder of adults. It can be classified as low red blood cells, low hemoglobin, or both. But ultimately, all anemias cause decreased oxygen delivery to tissues, which is always problematic. Cause here primarily is bone marrow damage, but you can also just have a lack of erythropoietin, and a lack of nutrients like iron, B12, folic acid, which we'll talk about. Bone marrow damage is a major cause because it's where your red blood cells and immune cells are produced. So if you have damage there, your red blood cell count's going to go, it's going to be bad. Clinical manifestations are going to vary drastically in severity and speed of onset. It can be super fast, super slow onset, just depending on how severe of anemia we're talking and how well the body can compensate. In general, though, you're going to see levels of pallor, paleness, tachycardia, dyspnea, that shortness of breath, fatigue, low blood pressure, and then you can have that fun trio of headaches, dizziness, and lightheadedness. Blood loss anemia, super simple, don't overcomplicate it. You lose blood. If you lose blood, you have low red blood cells. So you have an acute hemorrhage of some sort. And some people can actually have blood loss anemia with chronic bleeding and also menstrual disorders. If you have a super heavy menstrual flow, that can cause blood loss anemia over time. If, maybe you bleed through a period for 2 or 3 weeks a month, that's, not normal and can classify as blood loss anemia. Iron deficiency anemia is probably the one that you guys hear about the most. I have it. I'm sure I would put money on it that people on here have it. Super, super common in young women, especially. Um, it your body requires iron as a nutrient to synthesize hemoglobin. So when you don't have enough iron, your iron overall level is low and your body cannot make hemoglobin to the amount that it needs it at. So it can be caused by blood loss, pregnancy, alcohol abuse, NSAIDs, and also just not getting enough in your diet. That's a big cause as well. Diagnostics, there's just lab tests for that. You can have decreased ferritin and decreased hemoglobin. Your signs and symptoms vary with severity again. It is typically a slower onset, and because of that, your symptoms can range from super minor headache and fatigue all the way to dyspnea, profound hypotension, weakness, etc. For your iron deficient anemia, there are two medications to know. Ferrous sulfate here is an oral medication, so given PO. Common adverse effects are going to be nausea, black stools, constipation, teeth staining, and the toxicity is liver damage. So when you look at these adverse effects, I might have a question on this. Maybe I'm giving it away, but whatever. Black stools and constipation, those are not going to be life-threatening adverse effects. Those are expected findings. Are they not ideal? Sure. No one wants to be constipated. Let's be real. But it happens with the administration of this medication, so that's an education point. Hey, don't freak out if your stools are black. Hey, if you're constipated, let's talk about your diet and stool softeners and fluid intake, etc. Liver damage, though, that's a bad one. That's one you want to be on the lookout for. You want to, again, monitor those liver enzymes and teach your patient potential signs and symptoms of liver damage so that they can watch for that too. Iron dextran then is given IM or IV, so this is a different route. If it's IM, you use that Z-track method that you learn in skills. If it's IV, that preparation has to be diluted and given over several hours because there's a high risk for anaphylaxis. And your kind of adverse effects here to watch for are tachycardia, hypotension, and shock. So those are pretty significant adverse effects to look out for with iron dextran. Aplastic anemia is the decrease of bone marrow stem cells from damage to the cells or bone marrow. So this was kind of going back to what I was talking about at the beginning, where your bone marrow is responsible for the production of a lot of these cells. Aplastic anemia causes pancytopenia, pan meaning all, cyto meaning cells, penia meaning low. So all your cells are low. Low red blood cells, low white blood cells, low platelets. When you look at that, know what those mean. Know, low white blood cells increases your risk for infection, and you have to do those infection prevention type things. Know low platelets increases your bleeding risk, and you have to, be careful and don't fall and all those types of things. So these can cause life-threatening infections and bleeding. Lots of different causes here, congenital, secondary to certain drugs. A lot of it is still unknown. So again, those clinical manifestations are low white blood cells, red blood cells, and platelets. Those are just the fancy word for all of those three things. Treatment is going to be supportive. You're going to assess for bleeding and infection as a result of the neutropenia and thrombocytopenia, immunosuppressants, and epoetin alpha and filgrastim, which are right here for you. So epoetin alpha is a medication that's going to increase your red blood cell count for patients with low hemoglobin. Adverse effects are hypertension, joint pain, nausea, vomiting, diarrhea. There is a black box warning for thrombus formation if given when a hemoglobin is over 12, which you shouldn't be giving epoetin alpha in a patient who has a hemoglobin over 12 because 12 to 18 is normal. But you want to make sure, triple check those labs before you administer it that their hemoglobin is under 12. And that effectiveness is going to be measured by improving hemoglobin levels. So when you think epoetin alpha, think red blood cells and hemoglobin as a little group. Filgrastim then is going to stimulate the growth of white blood cells, and it'll help prevent infection by decreasing your neutropenia. So filgrastim, white blood cells is its own group. Megaloblastic and macrocytic anemias include folic acid deficiency anemia and pernicious anemia. In both of these anemias, you have red blood cells that are large and abnormally shaped, making them kind of ineffective. They can't do their job as well as they could otherwise. A lot of times, there's not really a bunch of symptoms until it's more severe and advanced. Folic acid deficiency anemia, as the name suggests, is caused by a decrease in folic acid, primarily via intake. And pernicious anemia is caused by a vitamin B12 deficiency. With pernicious anemia, you have an absence of intrinsic factor, which is required for the absorption of B12 in your GI tract. So because of that, oral replacements will not work. You can't take oral B12 to take care of that deficiency and help your pernicious anemia. Because the issue isn't the B12, the issue is your intrinsic factor being gone, meaning that you just can't absorb your B12. So if you take oral pills of B12, hey, that's great. It's not going to do anything. It just won't work. Clinical manifestations, you're going to have all those signs and symptoms of anemia overall. And then you're also going to have, this one is unique here, a smooth, sore, and red tongue. That is super unique to these macrocytic megaloblastic anemias. Pernicious anemia, if severe enough, can also produce neurological symptoms, which is another differentiating factor there. Diagnostics, you can do, those folate, those B12 levels, and then also to figure out if it's pernicious anemia, you can do an intrinsic factor antibody test. And this is just going to help see if you actually have that intrinsic factor to allow for digestion of B12 or absorption of B12. So treatment, B12 replacement if pernicious anemia, but not PO. A lot of times people can go in monthly or biweekly or do it at home, like IM injections. We're just not going to do PO and folic acid replacement if indicated, if it's folic acid deficiency. Hemolytic anemia is when there are decreased red blood cells because the red blood cells themselves are just dying faster. They have a shortened lifespan. In general, when your body's in a state of hypoxia or certain tissues are hypoxic, your body's going to be triggered to stimulate to produce more red blood cells. And that function still works in hemolytic anemia, but the issue is those new red blood cells that are produced still die too fast. Your body can have a field day producing all the red blood cells at once. They're just not living long enough to be fully effective. So that's kind of that pathophysiology there. Sickle cell disease, this one's definitely important to understand. It's a hereditary disease where the hemoglobin is an abnormal shape and it's sickled, hence the name. It's kind of like a half moon or like a U. And it causes adherence of hemoglobin to cell walls in your small vessels. Because of that, it can cause ischemia, that impaired blood flow, causing pretty severe pain and swelling and sometimes fever. The pain from sickle cell disease and a sickle cell crisis is extremely severe. It is not just a little bit of soreness. These patients can be in a lot of pain from that ischemia. They can present with chronic anemia, jaundice, bone abnormalities, and those pretty serious ischemic episodes that are referred to as acute sickle cell crisis. When you have a patient in a sickle cell crisis, your number one priority is oxygen administration. Because when you have ischemia, you're not getting oxygen and blood to the tissues at the rate that you need it to be there. So you need to kind of push for oxygen. Opioids for pain control, again, it's very, very painful. So you use opioids. You're going to promote IV hydration, warm compresses for pain because warm acts as a vasodilator. Heat is the vasodilator, so that'll help ischemia. And in some cases, they might need blood transfusions or other supplements. Sickle cell currently has no cure, but treatment for it is becoming more kind of concise. And we have a medication called hydroxyurea. This is a medication that decreases the formation of sickled cells, which in turn decreases the amount of crises and need for blood transfusions. So it's not going to eliminate sickle cell all the way, but it can help reduce that number of sickled cells that are circulating in the bloodstream. As the nurse, you need to know that you manage acute crises with oxygen, pain control, hydration, and blood transfusions. And you can aid the patient in lifestyle modifications to help them identify triggers of a crisis. A lot of times with sickle cell crisis, there's a trigger that causes this horrible ischemia that causes pain and all these different symptoms. So if you can kind of work through, what led up to this crisis, maybe you can help them identify those triggers and work to eliminate them when possible. We're almost done, guys, I promise. Thalassemia, pretty limited information that we talk about. It's an inherited hematological condition, most common in the regions of the Mediterranean, Africa, and Southeastern Asia, and it causes impaired hemoglobin synthesis. So these hemoglobin are dying too fast, and they're also super rigid. So again, just ineffective as they work through the body. They're not going to be great at carrying oxygen. I think this is the last slide before some practice questions for you guys. Polycythemia, poly meaning lots or many or more. You have increased erythropoietin production, which increases your red blood cells and the number of blood cells that you have circulating. This leads to a hyperviscosity of your blood and more blood in your intravascular space. In a patient who has COPD and chronic hypoxia, you might see this more often because, again, that state of hypoxia is stimulating that response to produce red blood cells. So, if you're in a chronic state of maybe low-grade hypoxia, your body's going to be trying to make up for it with red blood cells like nobody's business, which is just an overcompensation. Treatment, you can do therapeutic phlebotomy to decrease blood volume. It's exactly what it sounds like. We're taking out some blood. You have too much, we're taking it out. Neutropenia then is low neutrophil count. And if we remember, neutrophils are responsible for fighting infection and a bunch of other things, but that's the big one. So with your neutropenic patients, there is a high risk for infection. And again, that's great if you know that. That's the great starting point. But you have to think a little bit farther and say, okay, they're at an increased risk for infection, but what does that mean? What changes do I have to make as the RN to limit their infection risk and exposure? And there are no real symptoms. It's really just that they're at an increased risk for infection. A patient was diagnosed with pernicious anemia. After reading about it on Google, she learned she needed B12 supplements. She began taking oral supplements from Walmart. What education should you provide to the patient? Yep, that one is going to be D. If someone has, I also just want to clarify so I'm not confusing anyone. If someone has a B12 deficiency, that doesn't mean they have pernicious anemia. I have a B12 deficiency. I'm, long story short, I'm vegetarian, so I'm low in iron and B12. But I don't have pernicious anemia. So I can take PO B12 and it works for me. But in your patient with pernicious anemia, their cause of low B12 is the absence of intrinsic factor. So that's just a key differentiator there. Which of the following is false regarding ferrous sulfate administration? Awesome. Yep. Iron dextran is the one that's given IM or IV. Which of the following interventions for a sickle cell crisis would be inappropriate? Awesome, guys. Yep, that's going to be an ice pack. Ice causes vasoconstriction, which will worsen that sickle cell induced ischemia. So yep, you'd want to use heat instead. Which of the following medications would reduce someone's risk for infection? You guys are going to kill this exam on Thursday. You guys are like that with it. Awesome. Increases white blood cell count. Yep. Perfect. Okay, so here's the attendance QR code if you missed it. If you are comfortable, throw in the chat if you'd rather me do an in-person meeting or Zoom for the final review session. I didn't know that was an option, to be completely honest. But if a lot of people are preferring in person, that is something I can do. Or maybe a lot of people just still prefer Zoom, and that's totally okay too. Oh, that is right. A lot of you have, you're from Springfield too. I have to keep that in mind. Let me stop recording and we can chat. If you want to go, feel free to go. That's everything I have for you guys tonight. Um, let me stop
For
recording.
adult 1